Thank you very much. I appreciate the opportunity to talk to people about GME. One thing I will say before I go into my slides, which I'm going to roll through fairly quickly, unfortunately, is Joan mentioned before a poster that we have. It was a study that I did in our department because I worry that how we define educators in GME as well as in medical student education, it really doesn't fit the needs and the learning needs of the current students that we have. We still look at education as going in and give a lecture. You are promoted based on how many lectures you gave and whether or not it was a good quality lecture. Especially for women, we need to know whether or not that actually makes any difference, since we have issues just being women and getting promoted. So the studies show that actually the current generation, as anticipated, learns better and expects to be taught with hands-on education, yet that's not what we're providing. So we're using, it's almost like a quality improvement initiative. We're using the process measure of how many lectures did you give, because we can measure it, rather than using sort of the education equivalent of a patient-reported outcome measure and teaching the residents as they would like to be taught. So going on to my slides, what do we need to do to address wellness? I can say it really fast. We need to do a lot, pretty much overhaul education. First of all, we need more research, and if you're interested more in this topic, I'll be expanding on the issues of burnout among female residents during the breakout session. But we need to know more. When does burnout start? What are the individual, institutional, societal risk factors for burnout? Because we hear a lot in addressing burnout that we need to do yoga, and we need to do mindfulness training, and we need to relax, and we need to sleep, and that's great. But you can be as stretched out and rested as you want to be, and you can still be burned out, because it's not a personal issue. There are personal factors, but it is an institutional and societal issue. And unless we address those, we're not going to fix the burnout issue. What does wellness look like? We talk about burnout. What's wellness? Well, wellness is just doesn't mean that you're not burned out. Wellness is a step above, that you've really achieved the maximum of what it is that you would like to achieve. And how do various individual, institutional, societal factors contribute to wellness, and what do best practices look like? Understanding that during training there is a balance, as we have throughout life, of what you need to do, what you're expected to do, and what you have time to do. So any interventions need to identify and address a personal, societal, educational environment and work issues. Starting off with self-care, understanding that self-care is not in conflict with altruism, and unless we take care of ourselves, we're not going to be able to take care of anyone else. And I'm as guilty as everybody else here in not taking care of myself and getting the input from my rheumatologist of, if you don't take care of yourself, think about how many other people who are going to be impacted. So even if we don't do it for us, let's do it for everyone else. There was a study that we'll be talking more about that you can see on a couple of posters that we have here that we'll be talking more about at the breakout session. We did a study of our residents and found out that more women than men were stressed out or burned out, which was not a surprise, primarily in the PGY2 year. So we got a group together of female PGY3s to find out why they thought they were burned out as PGY2s. So what came up consistently was the need for self-care, and again, we need to normalize it, that taking care of yourself is okay, and it actually should be part of what you do. Things that our residents suggested was get a gym membership, hire a house cleaner, purchase advanced meal preparation. As a GME community, can we assist with that? It doesn't mean we need to pay for it, but can we identify it? If you fly in from halfway across the country and you're living in a city you've never been before and you don't know anybody there, how do you know how to find daycare? How do you know how to find somebody to clean your house? Can we develop resources where we can make that available to the residents when they come in? Looking at institutional interventions, one of these is addressing imposter syndrome that I'll be talking more about at the breakout session. Imposter syndrome is more common among women than it is among men. It's the feeling that despite all this objective input that you're doing well, you don't think you're doing well enough, so you want to continue to push the envelope. We know that people with imposter syndrome are less likely to speak up or volunteer because they're afraid of being wrong. So how do we teach them? Well, we get away from pimping, because all pimping does is make them feel worse and makes them retreat more into their shell. We know that imposter syndrome is worse when there is a change and you're stressed out and you're doing something you're not comfortable doing. This is where the mentoring and the networking will help, because we can show them that this is okay. It's normal to feel stressed out if you're doing something new, but we can help you through that. And so again, there are social support mechanisms. Our group at the university recommended having a structured advising program, having opportunities to know what life is like during and after residency, And getting groups together of women residents who are across programs, again, to normalize it and show that there are ways of getting through this. The other thing that was recommended is professional development, and this is supported by the literature, that women, especially as they get further along in residency, if they've not been exposed to playing on sports teams, or they've not been exposed to leadership or being in control or understanding how teams work, don't inherently know how to lead. So you're giving them some other stressful situation that they have issues in handling. So can we work with them and teach them leadership skills, to teach them how to run a team, because for the rest of their lives, they're going to be running teams? Can we show them how to do time management? Can we work on negotiation skills training, understanding that negotiation skills are different for women than they are for men? And then this HWI as homework interaction. We know that there's negative homework and work-home interaction, that the incidence of that and the impact thereof for both of them are higher for women than they are for men. It is both an institutional and a societal issue, but how do we address this? We can't just say it's a societal thing and we give up. We look at things like maternity leave, support for breastfeeding, support for daycare, support for family leave. It's not just taking off when you're younger because you're having children. Later on in your practice, you're taking care of elderly parents or family members or spouses. How do we support people when they need to take time off for their family without having them feel guilty because they're not at work? And then the old bugaboo, discrimination and harassment. We know that the presence of both of these increases the risk for depression and burnout. We need unconscious bias training, and there needs to be a culture change. We also need to encourage people to speak up if they've been a victim of discrimination or harassment. Many people, especially residents, don't speak up because they think there's going to be a negative impact. If you're a student and you speak up and there are presumably negative consequences, you would have the option potentially of going to a different medical school. If you're faculty, within limits, you can move on. What do you do if you're a resident? You're stuck in an institution where there's bias and there's discrimination. Do you change programs and go to a field maybe you didn't want to go into? Well, you're still in the same culture. Do you apply to the same field in another program? Well, we know as tight as residency slots are now, getting the same in a position in the same program in another institution is going to be next to impossible. So my concern with discrimination and harassment are residents, because you're stuck in what do you do? And so we need to change the culture. We need to know what's going on, but we also need to have a very clear reporting mechanism, because residents don't report because, again, of negative consequences. The other thing they bring up is they think nothing's going to be done. And so if we have a clear reporting mechanism, show them that something will be done, then there are some options. Unfortunately, the good old online sexual harassment training, you guys have to take that every year at your institution. Yeah, it does a lot. Actually, most studies will show you that after you take online sexual harassment training, your risk of unconscious bias is actually higher. For people that go in with biases, they feel their biases have been confirmed. For those, especially women, who come in without having biases, those women leave feeling disempowered, and they held biases against their own sex that they didn't have going in. So online sexual harassment or unconscious bias training does not work. It actually makes the problem worse. And so when your institution says, but we provide this, say, and what else do you do? However, there is indication that in-person sexual harassment training, where you have the opportunity to ask questions and be validated, actually is effective. So, thank you.